Yeah, good morning to everyone. And my task is to talk about the examination of the hip joint. And during my presentation, I'll take you through brief about the anatomy part, which is very essential. Though we are not reading it out, but I think we should be well versed about the anatomy part as well, because so that we can gather the information like what is the culprit, that why the pain in the around hip joint. So, as we all know, hip pain is a very common and disabling condition that affects patients of all age group, and the differential diagnosis of hip joint broadly based on the clinical history and the examination. And in spite of certain, like diagnostic facilities available, but it still is in few patients is quite challengeable. And patient often express the pain either in the anterior part of the hip or posterior hip pain or lateral hip pain. So pain in these areas has the different clinical condition which is responsible for the hip pain. So as I've said that anatomy is very important before we go ahead for the diagnosis or examination of the hip joint. And history plays a very big role in any clinical condition. So everybody needs to spend little longer time for the history taking, because if you've taken proper history, then half of your job is already done. Then of course clinical examination. Here I had shown this slide for the what are the clinical condition which could lead to the pain in the children in the hip joint. So their condition like transient synovitis, osteomyelitis, they are occurring less than 4 years of child. Between 4 to 10 years, the transient synovitis, Perthes disease, is the commonly seen. And between the 10 and 16 years of age, the slipped femoral epiphysis, avulsion fractures are very common because they become more active or they start taking participation in the sports activity. But any pain in the leg or joints, so one must go for the CBC evaluation to look for leukemias. That is also very common cause for the pain. In that condition, child always look more sick rather than to be little active if you compare with the other kids who they don't have any these kind of problems. So here is the protocol like normally no imaging is required where the symptom is less than 5 days. Child is not looking very sick and there is no history of trauma. Ultrasound is preferable on the radiology as like there is many complication on the early on gonadal system if we'll go for the pelvis x-ray and other things. And our part of the world, the radiographers, they are not really not taking care of this, so that they're exposed to the radiation and they're likely develop in the future the problems. So X-ray is just good to delineate the osseous pathology. MRI when the child is sick or prolonged complaints or other things cannot be able to diagnose the disease, then MRI is the better proposition. And any bony pathology, the CT is better option. And where there is osteomyelitis suspected, then bone scintigraphy may be advised. Anatomy, I'm not going to go into detail. It's a ball and socket type of synovial joints which connect the pelvic girdle to the lower limb, and the articular between the large bone horseshoe shaped with the deficient inferiorly, there's a vestibular notch which you can see. There are certain ligaments that's also important, like if they're lax or strained or sprained, that also could lead to the pain around the hip joints. Then we also need to know what are the muscles. If they are deficient, then they lead to, the region for the hip pain, like gluteal muscle, which medial and the medius they abduct and the medially rotate the hip joint, whereas the gluteus maximus which extends and the laterally rotate the hip joint. Quadriceps, like it have four components, among which the rectus femoris, which originate from anterior iliac spine and acts as the flexor of the hip joint. So there are certain muscles which act on the two joints. So we ought to know about what are those muscles to better delineate the pathology. Iliopsoas is the primary hip flexors. Hamstring is responsible for hip extension and the knee flexion also. That's also working the two joints. These are the functional group of muscles which are acting on the hip joints. Iliopsoas is major flexor muscle, extensors is adductor magnus and the gluteus maximus. Adductors are the adductor longus and brevis. Abductors are the gluteus medius and minimus. External rotators is obturator externus piriformis. Internal rotators gluteus medium, minimus and tensor fascia lata. And these are, in this picture you can see the what are the nerve supply for the hip joint. The major nerve are responsible to supply around the hip joint is femoral, obturator and the sciatic. And the blood supply is very important to know. Sometimes it is being question asked in the first part of the MD paper, anatomy of the hip joint and the clinical importance. So you ought to know about the blood supply, and it's also required to understand the avascular necrosis, why it's happening, that which artery may be responsible to cause avascular necrosis. So this is the things which you have to go through while you examine the hip, like history, general examination, gait, then like every joint examination you have to go for inspection, palpation, range of motions, measurement of any shortening or disparity of limb length, and sometimes special tests are required, which we are going to discuss in the next few slides. And these are the common features in the hip pathology, like pain, swelling, loss of range of motion, the limping or limb length discrepancy. And we all know that pain is most important reported symptom. If it is reported in the anterior hip pain, then it could be contributed with arthritis, any strain, bursitis or labral tear. If it is on the lateral side of the hip joint, then the greater truncated bursitis could be the responsible to cause the pain. If it is in posterior hip region, then hip extension and external rotator pathology or degenerative disc disease. Sometimes pain, there is a disc and the referred pain may be in the hip joint. As Dr. Minal has already mentioned that in any history we should know like when it had happened, the symptoms, what was the character of the pain, is there any radiation, because if radiation down in the leg, then there may be some other problem from the spine which could contribute to the hip joint pain. If it is just radiating around the groin area, then maybe because of inguinal hernia or groin strain. And other important thing to ask is like, did they had any history of fall? Did they start having pain after any gaming or playing activity? And pain those could be relieved with the prolonged exercise like in osteoarthritis of the hip joint. And then also we should inquire about the pain was gradual or sudden in onset. Because if sudden in onset, the trauma could be responsible for this. If it's gradual, then rheumatoid or osteoarthritis may be there. Then, of course, we need to know about what are the aggravating factors and how it is affecting their activity of daily life. So, detailed history is a must for each and every joint examination. Then we have to see, like, inspect for the swelling, what is the site, when did it happen, what is the duration, if it associated with the pain, or is it progressive over the period of time, because if there is an infective pathology that might get worsened over the time, or maybe the chronic inflammatory diseases also they could worsen over the period of time. So these are the important things which we need to look for. limp is another thing which during the examination we have to look for, because normally patient doesn't know that like he or she is having limping, but usually noted by the kin, and we should also know that what's the onset, duration, again about the association with pain, progression, and the ambulatory status. Does it affecting, is it tiring early with the limp, means there is energy consumption is much more while person is having limp, is because there is no bipedal movement. Then of course the past history is also important. So is there an history of trauma, history of any infection, any surgery was done around the hip joint, and any history of steroid intake, etc. Personal history is also very important to know about the occupation, the work tolerance, what kind of diet they've been taking, history of alcoholic or smoking abuse. Sexual history is also important. Menopausal history, because to know about the osteoporosis could be the cause for the pain around the hip joint. In sexual history, like during the abduction, there might be labral tear or maybe the arthritis in the hip joint or impingement could lead to the pain. That's why the sexual history is also important to note down. Again, family history, like for TB in the close relative, any dysplasias, to know about the DDH, metabolic storage disorder, inflammatory arthritis, etc. Sometimes they are genetic in nature, so which could also lead to inflammation in the child also. Then general examination, which is common for every entity, height, weight, BMI, any history of fever, what vital sign, pallor, lymph node examination, or chest examination to know about the spondyloarthropathies. This already I have said, like inspection, palpation, movement, range of motion, measurements, like limb length and special test. So first we would like to see the gait. It's a mode of walking which is rhythmical bipedal biphasic walking in which the lumbar spine, hip and legs moves in unison. And limping is the most common abnormality defined as abnormality of normal rhythmic biphasic walking. It could be like antalgic gait, waddling gait, short limb gait. Other abnormality, Trendelenburg test has been already discussed by Dr. Manal. Then circumflexion gait. Then gluteus maximum gait, where the patient will lurch backward during the stance phase. Quadriceps gait, where the weakness of the quadriceps muscle, the person will move forward to shift the TK line anteriorly to stabilize the knee joint. Then toe in gait and toe out gait. This could be seen in, like toe in is in the femoral anteversion and the toe out gait in the femoral retroversion. So that also need to be seen, which could lead to the abdominal stress, could cause the knee hip pain. Then of course the attitude of the limb, like standing and the supine position both. Then inspection from back, look at the spine for scoliosis, any wasting is there, any positioning of the PSIS, posterior superior iliac spine, back of the iliac crest or any scar or sinuses, to know about any infection had happened earlier or any surgical procedure has been done on the person. Then we have to look for limb length discrepancy. In palpation, we need to confirm the finding of the inspection, like local temperature, which is increased in acute arthritis, joint tenderness, like anteriorly, which is 2 centimeters below and lateral to mid-inguinal point, that we have to look for. Posteriorly, the junction of middle 2/3 and lateral 1/3 of a line joining greater trochanter and posterior superior spine. That has to be seen, that where is the tenderness is there, to know about what is the region of the pain. Then other areas also look for tenderness, ASIS, GT, BSIS, pubic symphysis, SI joint, and ischial tuberosity. Then palpation we need to see at the mid-inguinal point for the femoral artery, because if there is a dislocation of the hip joint, then the pulsation would be absent. Then we need to measure the deformity also. Like fixed flexion deformity, if it is unilateral, then we can go for the Thomas test, which is very simple. No, like we have to obliterate the lumbar lordosis, and then we have to see that how much flexion is there at the affected hip joint. If it is bilateral, then child or person may be hanged at the side of couch, and then we have to extend the hip joint, and then we look for that how much deformity there. In fixed adduction deformities, which is always compensated to have the convexity toward the normal side and the pelvis being tilted, causing apparent shortening of the limb. Whereas in hip abduction deformity, convexity toward the affected side by the pelvis tilted, causing apparent lengthening of the limb. So this is also important to note while somebody is coming to you for the hip pain. Then we have to look for the any fixed external or internal rotation deformity. Then movements like flexion. These are the position in the picture. So you need to adopt these things, like in daily practice so that you don't miss out anything. Like extension for the both gluteus maximus and the hamstring. These are the position that how it can be done. Then abduction, adduction, external and internal rotation. Then we have to look for any wasting that is there or not. And then limb length measurement. Because that you can observe by looking at the ASIS that there is a pelvis obliquity there, the shoulders, they are not in the same plane. Then you may think of like the person might be having the limb length discrepancy, which could be again apparent and the real one. Apparent is measured from the any fixed part like Jeffrey-sternum or umbilicus to the medial malleus, and in the apparent you don't have to correct the deformities or you need not to square the pelvis, whereas in true length, like anatomical length, there you have to make the pelvis square, and whatever deformity is there on the affected side, that need to be compensated on the healthier side to correct that one, and then measure the limb length from the ASIS to the medial malleus. So actually this is a standard thing. If true shortening is equal to apparent shortening, there is no compensatory mechanism happen at the limb. If true shortening is more than the apparent shortening, the deformity is compensated by tilting of the pelvis. So one might have the fixed abduction deformity. If true shortening is less than apparent shortening, then fixed adduction deformity may be happen. Limb length discrepancy could also be measured by looking at the segmental shortening, which is very quick method to do it, by flexing at the hip and the knee joint, and then you look for whether femoral shortening is there or tibial shortening is there. Or you may equate both the malleus also, so you would know like the leg shortening is there or not. Then these are the Bryant triangle and Elton line. This need to, if they change, like then there is a likely chance that there might be dislocation at the hip joint. So always you have to compare with the affected hip versus non-affected or healthy. Then only you will have comparable result to know that there is a change in the angle or not. Like these are the chains line and the shoemaker's line. This has to be done like for the supratrochanteric shortening. The line could be done by joining the two SIs with two GTs parallel to each other. So whatever the angle is there, that you have to see, and then you can measure whether supratrochanteric shortening is there or not. Then Morris bitrochanteric test, it measures the distance between the GT and the pubic symphysis on both the side, and it is reduced in the cases of the hip dislocation. These are the causes for the true shortening, supratrochanteric versus infratrochanteric. Supratrochanteric may be coxa Percy's disease, subcapital femoral epiphysis, malunion fractures, infratrochanteric like malunion, fracture femur, or maybe person who had affected with the polio that led to poor circulation and the poor bone growth. Telescopy is being done for the instability at the hip joint. Then vascular sign of Naret again to be seen, femoral pulsation to be seen to know about the dislocation of the hip joint. Tendelbach we have talked. Developmental dysplasia to manure could be done Barlow's and the Ortolani test. For Thomas test for the joint contracture. Ober's test is done for the iliotibial band tightness. Ellis test for the rectus femoris contracture could be done. Phelps test to detect the contracture of gracilis muscle, in which like person will be lie down prone and then you have to abduct passively and then flex the knee joint so that at least you can relax the gracilis muscle. Still you can go again passively more abduction, then there is a problem with the gracilis muscle contracture. Then Craig test for the femoral anteversion, the piriformis test, in which the hip is to flex at 45 degree, knees again flex 90 degree, and with one hand you stabilize the pelvis, other hand pushes the knee to the floor causing internal rotation. So a pain you feel, there is a patient feel that is local, then it is piriformis tendinitis. If it's radiated down, then it is a piriformis syndrome. Then Faber test to know the pathology at the SI joint. If pain is posterior, then it is SI joint arthritis. If pain is anterior, then the hip arthritis. So you can differentiate with the Faber's test. Then lateral pelvic compression test, anterior pelvic compression test to know about the pathology at the SI joint. Then other stress tests like pubic symphysis test, Snitfield test. And this Fulcrum test is for the to know about the stress fracture at the femur. But other things we should not forget, like examination of the another which is healthier one to compare the things. The other lower limb joint has to also be examined, and the proximal and distal like spine and the knee joint also be examined if the person is coming with the hip pain. And per-rectal examination may be required in very few cases where we are thinking of that any neurological problem which is responsible for the hip pain. So any laxity of tone or perianal anesthesia may be like which could lead to give you the information that there might be some disc disease which is causing pain at the around the hip joint. So it's very important to know to do certain clinical tests before we make a clinical diagnosis, or else we order for certain tests like CT, MR. So time to spend with the patient longer in history taking and good clinical examination will give you the more information rather than you quickly push on yourself on the investigations. Thank you very much.